Okay, this is going to be a presentation on two topics, the genetics of Alzheimer's disease as well as ethics. I'm going to start with Alzheimer's, and most cases of Alzheimer's are inherited in what I call a multifactorial fashion. There's genetic factors, there's environmental factors. We don't really have a single gene. That's most cases. Early onset Alzheimer's is defined as symptoms beginning before the age of 65, and this only represents about 2% of cases of Alzheimer's. Late onset is defined as symptoms beginning after the age of 65. This is the most common form. 25% of Alzheimer's have some type of inherited component. 10% of individuals over 70 have some type of memory loss, and memory loss increases to 25 to 40% by the age of 85. This is just a table I put together just as, to look at. So late onset, 15 to 25 have multifactorial. There are some genetic components. We see family, clusterings of this. And again, this represents 97% of patients with Alzheimer's. Early onset, again, less than 60 to 65, 99% are autosomal dominant. But this only represents 2%. So the early onset are Mendelian inherited and is autosomal dominant. And then there's Down syndrome. 100% of patients with Down syndrome will develop dementia, usually between 50 and 60. And this represents less than 1%. So let's just talk about this early onset, this little 2%. All genes are inherited in an autosomal dominant fashion. If an individual has an abnormality in one of these three genes, the risk to develop Alzheimer's is basically 100%. So the first one I want to talk about is APP, or the amyloid precursor protein. And this is about 10 to 15% of that 2% of early onset. And this gene is located on chromosome 21. So when we get to Down syndrome, and just remember this, the PSEN1 or presenilin-1, again, we're trying to name things better, represents about 30 to 70% of cases of early onset. And presenilin-2 or PSEN2 is about 5% of the early onset. So three genes, APP, PSEN1, and PSEN2, are autosomal dominant, and if you have one of these genes, you will develop dementia, a change in one of these genes. But let's talk about Alzheimer's and Down syndrome. Almost all individuals with Down syndrome develop dementia between 50 and 60. And one of the hypotheses is that the APP gene, which is located on 21, is hypothesized having an extra copy results in the early onset dementia. Now, the important thing for families, though, is if you're in a family with a sibling or an uncle that had Down syndrome and developed Alzheimer's, that does not put you at increased risk in the future. Now let's go to the meat of stuff, 97% late onset. Again, this is defined as developing symptoms of Alzheimer's after the age of 65. This represents 97% of all the Alzheimer's cases, and 15 to 25% are familial. That means we see clusters. Unlike the single gene inheritance noted in early onset Alzheimer's, this is usually multifactorial. It's kind of a susceptibility, not a Mendelian inherited gene. The one gene I want to talk about is the ApoE gene. And the problem with the ApoE gene is these studies were they were research studies, and people have run this into clinical practice, but I just want to talk about this ApoE gene because it provides instructions for a protein, apolipoprotein E, and this protein combines with lipids to produce lipoproteins that carry this throughout the body. And there's three ApoE alleles: ApoE2, ApoE3, and ApoE4. And so this is kind of a complicated slide, but I just want to talk about these different alleles and how different really they are. And so ApoE2, at site 112, has a cysteine, and a cysteine at site 158. ApoE3, a different allele, has a cysteine at 112 and an arginine at 158. And this is actually the most common allele. So ApoE2, only 8%, a little 8.4% of the population has this, and only 3.9% of patients with Alzheimer's have ApoE2. ApoE3 is 77.9% of the population has this, and 59.4% of the individuals with Alzheimer's, but again, this is the most common. And ApoE4, their arginine at both sites, 13.7%, 67.7%. Why the cysteine and arginine make a difference, I'm not 100% certain. It probably causes these apolipoprotein E to, have a 3D structure that's a little bit different. But 91% of patients with Alzheimer's have ApoE4. However, only 36.7% of patients with ApoE4 develop Alzheimer's. So that's a kicker, right? So in Alzheimer's, ApoE4, if you have two alleles for ApoE4, it puts you at increased risk. But if you look at all comers, this is the most common allele. So non-carriers of ApoE4, neither, so you could have three alleles, 2, 3, or 4. If you don't have a 4, only 20% of individuals that develop dementia by 80 have this. If you have one ApoE4, about 47% of patients with Alzheimer's have at least one copy of this, and homozygous, about 91%. But, that's looking at patients with Alzheimer's. When you have to flip back to the general population, this is when you get yourself into trouble, and why using this for clinical is kind of difficult. So the vast majority of the population has 2 ApoE3s. Okay, so 2 ApoE4s, as I said, can put you at increased risk to develop Alzheimer's over the general population, but it's not like, oh, you have 2 ApoE4s, you will develop Alzheimer's, which I'm going to get to in the next slide. But that's only about 1% of the population, or 5%. 2 copies of ApoE2 actually protect you from developing Alzheimer's. But again, the vast majority of individuals, ApoE3 is the most common of the alleles. I know this is complicated, and it's, again, I keep emphasizing, this is a research study that people have tried to flip back into clinical study. Because what they did is first they looked at, the population of people that had ApoE1, 2, and 3 in the population, and then they looked at the amount of people with Alzheimer's that had Apo 2, 3, and 4. So the general population risk to develop Alzheimer's, as I've said before, is about 25 to 40%. That's a general population risk. That's everybody's risk, whatever Apo they have. Now, the risk of developing of a patient with ApoE4 and no family history of Alzheimer's, so you got 2 4s, is 13.7%. Well, that's actually lower than the population risk, right? But you have 2 ApoE4s. However, the risk of developing Alzheimer's in an individual with 2 ApoE4s and a family history of dementia now is 45.9. So far higher than, higher than the general population risk. On the other hand, an individual with a homozygous E2E2 with a family history of dementia, their risk of developing dementia is actually below the risk. It's 5.9%. So from this, if you're ApoE4, you have a slight increased risk of developing dementia over the general population, which is 25 to 40% by age 85. But if you're ApoE2E2, you actually have a protection from that. Why? I don't know. So, symptomatic testing. Testing performed to confirm the diagnosis of clinical suspicion. Pre-symptomatic, genetic testing of an individual without symptoms. If an individual has an APP, PSEN1 or 2, Whether they have symptoms or not, they will develop Alzheimer's disease. If the patient is tested for a late onset predisposition, it really depends on the family history. So if the genotype is E4 with no family history, then the risk of Alzheimer's is actually not even, it's actually below population risk because the family history trumps this E4. However, if there's a family history and they have E4, it's 45.9, but they started with 25 to 40. So there's still greater than a 50% chance that it won't happen. On the other hand, if they have E2, even with family history, their risk drops. But, percentages are percentages. I have a lot of families that have babies with Down syndrome that had a quad screen of 1 in 4,000. So, if it happens to you, this is a percentage. This is not diagnostic. So this gets me into my next topic, which is genetic testing and ethics. And what is ethics? Biomedical ethics is a system of moral principles that guides medical care. Ethics of care, ethical theories focusing on relationships, sympathy, compassion, fidelity, friendship. And I know you've learned a lot of these in a lot of your other physicianship courses. But one of the things is informed consent, assent in minors, autonomy, beneficence and non-maleficence, utility, does it do any good, justice, confidentiality, and privacy, as well as duty to warn. Generally, ethics is a case-based study using examples to determine guidelines for future conflicts. And probably you've already learned this, that many individuals are unable to make decisions for themselves, including minors, incapacitated due to injury, illness, or age, mental and health disorders, intellectual disability, prisoners, and abuse victims. So, beneficent and non-maleficent do good to others and do not do harm, acting in someone's best interest and making clinical recommendations in the patient's best interest. So let's look at some examples. In surgery, when does surgical intervention cause more harm than good? Survival, quality of life, it's subjective over time. In the 50s, they did not do heart surgeries on children with Down syndrome, and that's not acceptable now because in the 50s, they didn't feel that they had a quality of life. But let's go to genetic testing. Is it always necessary to send a genetic test? And there's more and more genetic testing. Does the additional knowledge help or harm? Help, diagnosis, reassurance, information, harm, additional stress, costs, social blaming. And this gets into genetic counseling, explaining testing before you do it. Autonomy, the right of self-determination. A person makes a decision for themselves about their lives, and that's based on their decisions, and it requires intentionality, understanding, knowing the potential ramifications of doing a test, and freedom from constraints, external social barriers imposed by others, internal physical and psychological barriers. So let's talk about autonomy and genetics. Understanding the potential ramifications is really important. So genetic professionals, that includes clinical geneticists such as myself and Dr. Lee, as well as our genetic counselors, sit down with patients and talk about, do you want this test? What will this help us understand? And is there something that may not, you may not want to know? So informed consent is autonomy in respective persons, an individual making the decision after knowing all the facts, the procedure, the benefits, the potential outcomes. I have to tell you, people do more genetic testing now that it's just a cheek swab and they don't have to get their blood drawn. Any medical test or procedure should have prior informed consent, as well as minor assent. Even though the parent has to consent to it, it's important in a child, usually around 10 and older, that I help them to understand, if it's possible, what we're testing them for and involve them in this process. So let's go back to Alzheimer's. As I said, an 80-year-old man is diagnosed with dementia. He has a brother who also has dementia in his early 80s. Genetic testing identifies 2 ApoE4 alleles. What does this mean for his children? Even if his children carry 2 ApoE2s, one from the father, and say the mother has one as well, the risk to develop Alzheimer's with this family history is 45.9%. So it's still more likely than not that they won't. At this time, there's no medication which can lower the risk of developing dementia. And this is actually a really important thing. And we're going to, when we talked about breast cancer and things like that, I would be more into doing ApoE4 if there was some type of treatment that could lower the risk. If they don't have 2 ApoE4s, their risk is population risk. Let's talk about another one. And last year we talked about long QT or arrhythmias. So here we have an individual who has long QT, which is inherited in autosomal dominant, just to remind you guys. And his father's a police officer, and his father's brother is a truck driver. So what do you need to talk to? This long QT more likely came from mom or dad. But if dad tests positive for this, this could actually affect his job. And it definitely could affect the job of a truck driver. However, the truck driver could also get in a car accident because he lost consciousness, and then he also has children. And unfortunately, one of the first symptoms of long QT can be sudden death. So informed consent of minors, pre-symptomatic testing in minors, when is it appropriate to test a minor for a genetic condition? And one of the most important, and it's really a case-by-case, what's available, gene-by-gene thing. Age of onset. Does it occur during childhood in the general population or in the family? Because sometimes we've had cancer genes that in general don't present till 30, but sometimes in the family, we've seen people at 16. So that might change my decision. Is medical intervention available? We're going to talk about colon cancer, and there's a form of APC that you can get as early as 10. So, and it can occur during childhood, and we can remove the colon to prevent colon cancer. And the final thing is the minor able to participate in the decision? So one thing I want you guys to know about is GINA. And GINA is the Genetic Non-Discrimination Act. A lot of people don't know that this is present, and it was signed into law in 2008. This prevents an individual from being discriminated against based on their genetic history. They cannot be denied employment, or in most cases, except, again, if it was long QT and a police officer or somebody that drives a truck for a living. It does not apply to disability insurance or life insurance. Patients need to be informed of the possible consequences prior to performing the testing. So, and this is especially the long QT, and the reason I gave you this as an example is it is a difficult conversation that we have with our patients, because if they do have one of those jobs and there is a family history of long QT and they get tested, it's possible they could lose their job. And yet, if they don't get tested, they could die. The last thing I want to talk about is direct-to-consumer testing. And there are a lot of direct-to-consumer labs, like at 23andMe. And the genetic testing, the patient sends off on their own. The lab that performs this testing is not held to the same standards as a clinical lab is held to. There are no CLIA standards. And they'll perform any testing somebody wants with payment, But I just want to give you a recent example of something that happened. Somebody sent, they wanted all their genetic predispositions, so they sent it to 23andMe, and a man found out that he had a pathogenic mutation of PSEM1. There was no family history of dementia or early Alzheimer's. And so he went to genetics and they sent confirmatory testing. He didn't have it. The problem is a PSEN1, there's a 100% chance that you're going to develop dementia. People could actually kill themselves over this kind of testing. So, it's really important. I don't even, people try to come to see me to review their direct-to-consumer testing, and I'm just like, this is not a clinical test. It's fine that you spent like $100, but I cannot interpret this, and it's not considered medical. So, in conclusion, early onset Alzheimer's is an inherited and autosomal dominant fashion in most cases. So early onset, that 2%. Late onset, multifactorial. Individuals with dementia are vulnerable, and many factors need to be considered when performing genetic testing. And again, we're going to talk more about this genetic testing when we get to oncology and the breast cancer case and why we would test somebody. And this is a moving target. That's one thing I really want to emphasize with this. This is a moving target. People used to not have genetic testing because they didn't want it. And now, with CRISPR and all these new things coming along, we may be able to treat a lot of things if we know it. So does the benefit outweigh the harm? Does the patient or the family, in the case in pediatrics, understand what they're being tested for? It needs to be explained on the front end. I a lot of times get people who somebody says, oh, we can test you for blah, 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 and they do the test, and then it comes back with maybe some variant, and then they send them to genetics, and the patient, we say, did anyone explain what this test was or what they were testing for? And basically the answer is no. And so then we have to start from scratch. So now they're Dr. Googling, they're really panicked. We never have those problems when we spend the time on the front end. So even 2 minutes on the front end explaining what somebody's going to be tested for can help a lot of anxiety on the back end. So that concludes this presentation.